So, should I start?
Yes, sir.
So, good evening, everybody. I welcome you to this third postgraduate teaching program of Maharashtra Ophthalmological Society. In the month of December, we have started this online postgraduate teaching program, and topic which was decided for the month of December was retina. And for this month, we have decided topic as cornea. And this month, our coordinator will be Dr. Nikhil Gokhale from Mumbai. There will be two online PG teaching programs. 2 days will be the first teaching program, and next will be on 18th of January. And as we know that there will be 5 quiz questions at the end of the PG teaching program, and at the end of the year, we are going to have the final results of quiz, and then we will declare the awards for that. So for this PG teaching, actually we have two cases, and 2 lectures by stalwarts in that field. So I request Dr. Nikhil Gokhale to start today's program.
Thank you, Dr. Santosh. I welcome all of you to the MOS online PG teaching program. And at the outset, I'd like to thank our president, Dr. Santosh Bhide, Dr. Anaga Herur and Vardhaman for being so active. I think we are having so many scientific webinars. And the last 2 days, we also had very interesting program on OT sterility. So today we are basically going to have a session on cornea, which will be hosted along with DY Patil Medical College in Kolhapur. And so we will have 2 case presentations, one on pseudophakic bullous keratopathy and another one on fungal corneal ulcer. And to discuss the cases, we have with us Dr. Milind Sabnis. He is professor and head of department at DY Patil Medical College in Kolhapur. He is very active and has been a teacher for the last 34 years. And he has been an examiner for undergraduate and postgraduate courses and has about 26 publications to his credit. I welcome him we also have with us Dr. Rajesh Joshi, who is an associate professor and head of department of Government Medical College in Nagpur. He is also the editor of journal JCOR, which is the MOS journal. He has keen interest in cataract and refractive surgery and has been the secretary at MOS. We also have with us Dr. Bhatti sir, who is from Mumbai in private practice in Chembur, and he is also a teacher for the more than last 25 years for undergraduate and postgraduate students at JJ Hospital, Somaya Hospital, and the Railway Hospital. He has been the past secretary and president of Bombay Ophthalmic Association, and we all know him for his interest and innovation in computers, photography, and teaching. We also have with us 2 faculties who will present topics. One, Dr. Sushmita Shah. She is from Mumbai. She is a very active corneal surgeon. She'll be talking to us on how we would manage keratoconus in our day-to-day practice. And we have Dr. Ajay Kulkarni, again another corneal stalwart from Nagpur, and he will be talking to us on how do we manage fungal keratitis. So I'd request that we start without much delay and have the first case presentation followed by the discussion by our examiners. Thank you. The students are there. Maybe the first, I think, case is on bullous keratopathy by Dr. Sanket Patil.
Yes, sir. Should I start?
Yeah. Share your screen and you can start.
Okay, sir. Is my screen visible?
Yes, visible.
Yeah, visible, audible. Go ahead.
Good evening, everyone. So my name is Dr. Sanket Patil. I'll be presenting a case of pseudophakic bullous keratopathy under the guidance of Dr. Supriya Patil ma'am. So there was a case of a 55-year-old female presented to our OPD with complaints of diminution of vision in the left eye since 4 months, which was associated with intermittent photophobia and colored halos around lights. She also complained of pain and watering. There was no history of associated redness, itching, or discharge. Uh, Past ocular history, she had a history of cataract surgery in the left eye 5 months ago at a local hospital. There was no history of trauma. Past medical history, which is not significant. There was no history of addictions. In systemic history, all the systemic history was within normal limits and all the vitals were within normal limits. On ocular examination, the best corrected visual acuity in the right eye was 6/36. In the left eye, it was counting fingers 2 meters with PR accurate in all quadrants. Extraocular movements were full, free, and painless in all cases. Intraocular pressure in the right eye was 18 millimeters of mercury, and in the left eye was 14 millimeters of mercury. Pupils were round, regular, and reacting to light. On contact pachymetry, the right eye's corneal thickness was 510 micrometers, and in the left eye it was 620 micrometers. On sac syringing, both sides the sac was patent, and the confrontation test was normal. On slit lamp examination, right eye showed immature senile cataract, and in the left eye, there was a 7 millimeter surgical scar on the sclera above limbus, seen from 11 to 1 o'clock. As you can see in the image here, the cornea shows diffuse haze. Epithelium shows multiple micro and macrobulli. There is diffuse stromal edema. There is also mild thickening of the Descemet's membrane along with Descemet's folds, as you can see here. Endothelium had pigment deposits. Mainly in the pupillary area. Endothelium had pigment deposition mainly in the pupillary area. The fundus examination in the right eye was healthy and normal, and in the left eye, fundus was not visible due to hazy media, which was due to the corneal edema. So the ultrasound B scan was done, which was within normal limits. The investigations done were specular microscopy, anterior segment OCT, and pachymetry. These investigations were done in the right eye to rule out previously missed endothelial diseases. The anterior segment OCT showed a normal cornea in the right eye. In the left eye, there were bulli seen. There was increased stromal thickness and irregular endothelium was seen. There was no signs of Descemet's membrane detachment seen in this case. The specular microscopy in the right eye was normal. Specular microscopy in the left eye was not recordable due to corneal haze. Based on the clinical findings and the investigations done, patient was diagnosed as a case of pseudophakic bullous keratopathy of the left eye. The management was given, patient was given a bandage contact lens and hypertonic solution, steroids, lubricating drops, cycloplagics, and anti-glaucoma drugs for a period of 3 months. During this period, the bandage contact lens was changed every 1 month, but the patient did not have any relief with this line of management and was then posted for Descemet stripping endothelial keratoplasty, after which patient had a clear graft and best corrected visual acuity of 6/18. As you can see in this image, this is the post-op day 1 image of the operated eye and the anterior segment OCT done here. The lenticule is firmly attached to the tissue. There is no separation visible. So the key points to remember in this case is any patients presenting to the OPD with complaints of pain, photophobia, redness, or early morning blurring of vision after cataract surgery should be carefully examined to rule out pseudophakic bullous keratopathy. And the careful evaluation of the other eye is extremely important in patients with pseudophakic bullous keratopathy to rule out a previously missed pre-existing endothelial disease such as Fuchs endothelial dystrophy. Thank you.
Yes, Saket, that was a wonderful presentation, and I compliment Priya Madam also for managing it so well. But being a PG session, I would like to ask few questions, like what was the recovery after cataract surgery in this patient?
Sorry, sir, I didn't get your question.
You should mention about the recovery part after cataract surgery. Did the patient gain vision after cataract surgery, or it was delayed recovery?
Dr. Joshi is asking
It was a delayed recovery. The patient.
Yeah,
because in
Yes,
exam,
sir.
they will ask you, like, did patient get any vision after cataract surgery or not? What was his recovery? Because recovery nowadays is a fast, no? Either it's the phacoemulsification
Yes.
surgery or small incision cataract surgery. Because those are the key points which are important during examination.
what Dr.
Then-
Joshi is asking is that when the patient was operated for the cataract, did he see well soon after the surgery, or did he never see after the surgery at all?
So the vision was always 2 meters, up to counting fingers, 2 meters only. And the patient presented to us after a month of 4 months after the surgery, actually.
So this means that the patient never saw well after the cataract surgery.
Yes.
Now, interestingly, when you've done your DSEC, the anterior segment other than the cornea is well maintained, and the other eye also has a normal endothelium. So what do
Yes.
you think? What do you think was the cause of this bullous keratopathy?
So in this case, it would be because of the instrumentation. So there would be a instrument touching the endothelium, so endothelial touch during the surgery, or during the insertion of posterior chamber intraocular lens. The lens could have touched the endothelium, which could have caused damage to the endothelium, leading to pump failure.
What was the type of surgery performed?
So the small incision cataract surgery, sir.
Yeah, small incision.
Yes, sir.
Okay.
Do you know the preoperative status of the cornea?
In the left eye, no, ma'am.
And do you know, was it an eventful cataract surgery, or it was an uneventful cataract surgery? Do you have any documents revealing that?
No, ma'am. There was just history. There was no documents with
So
the patient.
in the history, did the patient say whether the cataract surgery took 5 to 10 minutes or whether it took 1 hour? Anything like that?
Yes.
So not significant. So no, sir. No, sir.
How long was the surgery? What did the patient say?
So about 15 to 20 minutes, sir.
Okay. Do you think that this could be some sort of TAS-like syndrome?
So in case of TAS, there would be hypopion present also, sir.
No, your patient has come to you a month or two later, and the anterior segment is generally well preserved. Only the endothelium is gone.
Yes, sir. So in case of TAS, the symptoms would have begun within 12 to 48 hours itself. Post surgery.
It seems that they were there right from after the surgery. No? You said the patient never saw.
Right, sir.
No, I think what sir is asking you is that if there is TAS, for example, and the patient has come to you after 2 months, what are the clinical findings in the anterior segment in a TAS as compared to a patient who has just simple bullous keratopathy for whatever reason? So if a TAS is there, what all additional things you might see? That is what probably sir wants to ask.
Yeah, exactly.
Or in acute stage, if you can tell us, like when you get TAS after 24 hours, you said, immediately patient has some problems. So what are they, or what is the clinical presentation of a TAS patient, maybe, immediate post-op? If you can tell us that, probably we'll know what will happen after 2 months as well? You may be able to answer that. No?
So immediately, so the patient would be complaining of pain, photophobia, watering. There will be hypopion in the anterior chamber, non-sterile hypopion.
Pain will be there.
Sorry, sir.
Pain will be.
Yes, sir.
Okay, in this case, you've managed it beautifully with a endothelial keratoplasty. Supposing you didn't immediately have access to an endothelial keratoplasty, any medical treatment you could try for a while?
So medical treatment would be, as we already gave, sir, the patient was on hypertonic solution. That was sodium chloride 5% was given, along with steroids, lubricatings, and anti-glaucoma drugs, sir.
Now that is temporary treatment. Is there any medical treatment where you could think perhaps you might get permanent relief?
Permanent relief, sir. Okay. So in the early stages, we can try ROCK inhibitors.
Okay, so you could try Rho kinase inhibitors.
Yes, sir.
In your experience of wherever you study, have you all had much benefit with these?
No, sir. We haven't tried it yet, sir.
You haven't tried it yet. Okay.
No, sir.
Okay.
What else you can try?
So if there's so if you want if the visual prognosis is already bad, then there could be anterior stromal puncturing that can be done, but it would lead to scarring. So there will be guarded visual prognosis. Other than that, so amniotic membrane graft can be given. Gunderson's conjunctival flap. Or
How does stromal puncture helps?
so it would relieve the symptoms of the patient. So as the we'll be rupturing the bullae with a 26 or 24 gauge needle. In a sitting, we would be giving around 300 punctures to the anterior stromal bullae. So the rupture and pain will be reduced.
Could that also sometimes improve vision?
So it would actually lead to scarring. So probably not, sir.
Okay, most of the time it wouldn't, but I think there are some reports that say that some visual improvement also occur. And now you also talked about a conjunctivoplasty. Would you want to do that in a bullous keratopathy in a potentially seeing eye or in a potentially blind eye?
So with guarded, extremely guarded visual prognosis.
See, obviously, when you do a conjunctivoplasty, at that time, the patient isn't going to see.
Yes.
Would you prefer this as an option for symptomatic relief only in patients who are not likely to see at all by any means? Or would you like to try this in the case you just did with endothelial keratoplasty?
No, sir. With when there is no visual prognosis in the future, only then, sir.
Can I ask you, why did you give steroids for 3 months in a case of established bullous keratopathy?
So to reduce the inflammation.
Yeah, I was quiet when you presented. If you go back to your picture, the first presentation,
Yes,
there was no inflammation. So what was the idea of giving a bandage contact lens and a hypotonic saline and steroids and anti-glaucoma? I mean, you say that the pressures were normal.
Yes, sir. So as
You're
we were
asking
giving,
for trouble. It's a compromised surface with the bandage contact lens, which is a foreign body, and 3 months of topical steroids. You're asking for trouble.
Right, sir.
I think maybe we
so
can.
So how early would you advise endothelial replacement surgery in a patient who has a developed bullous keratopathy? How early? If the other eye corneal endothelium is normal, if there is no evidence of primary endothelial disease in the form of any endothelial dystrophy, and a patient presents to you at say 2.5 to 3 months how early would you suggest surgery?
So we would first go for a topical treatment. If the topical treatment has failed, in a period of 3 to 6 months at least, after that only we'll go for surgical management.
Okay.
Thank you, Dr. Sanket. I think it was a nice case, very well managed. And I think you were able to answer most of our questions, and whatever questions were unanswered, I think maybe we can go back to the books and try to read them up. Should
Yes.
we proceed to the second case?
Yes, sir.
Yeah. The second case is by Dr. Kamakshi Panchal on fungal corneal ulcer. She can share her screen and start.
Yes. Is my screen visible, sir?
No.
Yet.
No.
Share, yeah.
Dr. Kamani, if it doesn't come in 30 seconds, please stop and share again.
Okay.
Just stop and share again.
Yes, sir.
Start sharing again.
I stopped. Just share again. Perfect. Just put it in slideshow, please.
Yes, sir. Good evening, everyone. Am I audible, sir?
Yes.
Good evening, everyone. Today, myself, Dr. Kamakshi Panchal. Today, I will be presenting the case of fungal corneal ulcer under the guidance of Dr. Supriya Patil, ma'am. A patient of 53-year-old male, farmer by profession, came to our OPD with chief complaints of pain, redness, and watering in his right eye. Since 7 days, patient was referred to our hospital from local hospital. There was history of trauma to his right eye with sugarcane leaf 10 days back. There was no history of any systemic disease and any previous ocular surgeries. At time of presentation, patient was instilling Netamet eye drop 1 hourly, Moxicip eye drop 1 hourly, and atropine eye drop twice a day. On examination, patient was fairly built, conscious, and cooperative, well oriented to time, place, and person. Systemic examination were within normal limits. On ocular examination, best corrected visual acuity of right eye was hand movements and PLPR positive in all 4 quadrants, with lid showing both lid edema. There was conjunctival and circumciliary congestion. Circumciliary congestion with cornea showing central corneal ulcer of stroma with stromal infiltrate of 5 by 5 mm in size, with feathery margins, oval in shape, with epidefect of 7 into 5 mm, and endoexudates with diffuse stromal edema and Desmond membrane fold. And ulcer was nasally progressing towards the limbus. Anterior chamber was well formed and with thick hypopyon of 1.5 mm in height. Iris was normal color in shape with pupil mid-dilated under mydriatic, and cataractous lens was there. On sex syringing, patency of sec was normal. Scraping of ulcer was done and sent for microbiological examination. Fungal hyphae was seen on KOH wet mount and no growth of organism seen on gram staining. Very gentle B scan was done to rule out any signs of endophthalmitis and posterior segment pathology. All routine investigation was sent, which all came within normal limits. In treatment, patient was admitted and started on netamycin 5% eye drops 1 hourly, voriconazole 1% eye drops 1 hourly, with antibacterial, cycloplegic, and lubricating eye drops, and systemically tablet ketoconazole 200 mg BID was started after the liver function test was came negative, and LFT was performed 2 weekly thereafter. systemically anti-glaucoma medication and analgesics were also given. Even after this treatment, patient was not improving, and also stromal infiltrate size was kept on increasing and deeper into the corneal layer. So we have posted this patient for intrastromal and intracameral injection voriconazole 100 microgram per 0.1 ml with AC was under LA, given 2 times 3 days apart. Even after this intracameral and intrastromal injections, ulcer was spreading towards the limbus and deeper into the corneal layer with endoexudate. So we have posted this patient for therapeutic keratoplasty under LA under extreme GVP, and corneal button was sent for culture sensitivity on blood agar and sebous dextrose agar, which came positive for fusarium on sebous dextrose agar on 7th day post-operatively. This is post-operative day 1 photo of after the therapeutic keratoplasty. Graft was clear in size, AC was well formed with air bubble visible, and patient had given vision of counting finger 1 meter. On first follow-up, patient had graft clarity was good with vision of best corrected visual acuity in his right eye was counting finger 3 meter tasted up. And patient is currently on topical antifungals, systemically antifungal, anti-glaucoma medications and analgesics with mydriatic, cycloplegic, sorry. Thank you.
Yeah, that was nice presentation. Just one comment. Whenever you are presenting, don't write down the trade name. Okay, always write down the pharmacological name of the drug whenever you are, and don't write down ED like usually you people write down ED. Write down full form like eye drop also. And why do you say fungal corneal ulcer?
Sir, firstly, there was a history of vegetative trauma was there, and feathery margins was noted on the presentation with, and most importantly, microbiological fungal culture was sent, which came positive on KOH mount for fungal hyphae. So it was fungal corneal ulcer.
Clinically, other findings?
Clinically, so there was stromal infiltrate with endoexudates and diffuse stromal edema and epithelial defect.
How many times you see corneal edema, diffuse corneal edema in a patient who has fungal keratitis? You said it's a central ulcer. I could see the pupil. It was paracentral. And you had given full antifungals with the evidence on KOH as well as the organism grew. So do you mean to say that it was not responding to netamycin, voriconazole, ketoconazole, itraconazole, multi-drug resistant fungus? What was it? Or you have missed something else? You were giving full antifungal therapy, yet the ulcer kept on increasing.
Yes, sir.
So could there be any other possibility? Usually you don't see this diffuse corneal edema in fungal keratitis. Could it be another organism causing toxin release which is responsible for edema? And you're presenting complaint, you said pain, redness and watering, and your vision was hand movements close to face. Patient would come and see that I am not able to see. Okay, inability to see should be a presenting complaint with such a large ulcer.
Yes.
So do you think that you were late in posting the patient for therapeutic PK?
Yes, sir. We have waited and we have tried giving intrastromal injections in between till tissue gets available.
Okay. But according to what pictures you presented, actually the inflammation increased after your intrastromal injections and intracameral wash.
Yes, sir.
Why is that?
So sometimes after intracameral injections and intrastromal injections, there are chances of.
What is the reason? Why?
So after the first injection, the hypopion came, hypopion was after the POD1, hypopion was not there, but it progressed after second day, and the ulcer kept progressing only. There was no healing agents were noted. So we posted him for second time intrastromal and intracameral injections, voriconazole. And thereafter, after also ulcer was kept progressing towards the limbus. So
in this case, what it appeared was that the abscess was limited to the stroma. That means maybe up to the descemex, but not going through into the anterior chamber.
Yes.
So when you did an anterior chamber tap or injection, what was the purpose of that?
So, sir, to remove the hypopion and to clear the endoexudates.
This hypopion is supposed to be sterile, isn't it?
Yes, sir.
So would it not just disappear on its own once you treat the abscess, or do you need to separately drain it?
No, sir, it will get clear.
So was there any purpose in doing an anterior chamber tap, or could that have possibly worsened the situation?
No, sir, there was, sir, endoexudate were also present, and hypopion was 1.5 mm in height, and it was not reducing with
coming back to the same question, that if you see a hypopion in a corneal ulcer, will you tap it?
Not every time.
Then when will you tap it?
There are specific guidelines when
there are chances of secondary glaucoma, and it was not coming down with systemic and topical antifungals. And ulcer size is more than 5.5 mm.
The other interesting thing was you said it was fusarium. Did you think of trying amphotericin B as a topical? Voriconazole is also good, but did you think of trying amphotericin?
No, sir. We have given voriconazole 1%.
Fine.
So now, in hindsight, if you given the choice, would you have tried Ampho-B in this case?
Yes, sir.
In what
How is
form?
amphotericin prepared if you want to use it as drops?
Sir, amphotericin is commercially available. First, dilute, the dose is 0.15 microgram per 10 ml. So we have to dilute it with.
It comes as a powder or as a solution?
It comes as a powder.
Powder. Usually how many milligrams?
Sorry.
Actually, I'm not sure. Okay, that's okay. Anyway, the graft was really well done. And in this case, I also noticed that the graft was fairly wide. That means it was almost limbus to limbus, and there was a little bit of white, that arcus on the donor cornea also visible in the final result. Now here, if you had a choice, would you try for a bigger graft or a smaller graft? I mean, the smallest graft necessary to cover the abscess, or would you like to have a little bigger graft?
Sir, bigger graft.
With reasons.
Yes, a bigger graft of because, sir, fungal hyphae can be present in borders, and clear margin of that. I would like to give the clear margin of 1 mm, so to prevent reinfection.
Okay, now when you're doing this graft for optical reasons or just as a support?
No, sir, to prevent infection and to maintain the globe and to prevent endophthalmitis, for to maintain structural integrity of eyeball.
Okay.
What is the dose of the voriconazole that you used intracameral or intrastromal, what you had used, no? And like, how do you prepare it, or from which solution you made it, or powder, or?
Yes, so dose was 100 microgram per 0.1 ml, which was voriconazole commercially available as voriconazole powder from 1 mg, in which we have diluted with 1 ml saline. After that, we have taken a tuberculin syringe 0.1 ml, so it was 100 microgram in 0.1 ml. And it was given with 30 mg, 30 gauge needle.
Can I add a comment?
Yes,
Yes,
ma'am.
please. Yeah, go ahead.
Yeah, so Kamakshi is a very challenging case and well managed. Now I will go back to Dr. Ajay Kulkarni sir's question that you have an ulcer, you scrape it, you get KOH positive fungus, no culture negative, and you start all antifungal and patient is not responding. So as a clinician, what is an additional thing that you can do at this point? Is there anything we can do to figure out the diagnosis, that whether you are missing something, which Dr. Kulkarni sir was trying to point at? No. Yeah. Anything else?
Yes, ma'am.
Could you have scraped the ulcer a second time?
Yes, sir. We could have. Yes, sir. We were doing scraping daily, and we could have sent it for culture and sensitivity. So by that we can able to know it was particularly which type of fungus was there, and then we could have added that particular antifungal.
Yeah, so the point is that not just which fungus, but maybe there was an additional bacteria, maybe it was a mixed infection and you have not picked it up in the first scraping. So when the microbiology gives you an incomplete picture and your treatment does not respond to the microbiological treatment, so it's always indicated that you repeat the scraping, do a repeat smear, do a repeat culture. Also, the corneal button, I don't know how many days it has been, so I hope you have done a microbiology of the corneal button. That can also give a definitive diagnosis about what could be the possible cause. So it will be tremendously useful in treating the patient. If you get a culture positive, if you've missed in the scraping, you get it from the corneal button, that will completely change the prognosis of how you treat the graft post-operatively. So this is one thing that whenever we are doing surgeries, I think it's a good idea that we send the tissues, etc., for the histopathology and the microbiology. And I think it applies to the previous case also by Dr. Sanket. I think it was very beautifully managed, but then the question still remains that we could not understand or we don't have a definitive diagnosis as to why the pseudophakic bullous keratopathy happened. And if that lady comes back after 6 months with a cataract in the other eye and you have to operate it, so then you don't know what you are addressing, because in that patient also there was no guttae on the slit lamp, there was no guttae on specular microscopy. So maybe when doing the DSEC, the endothelial the endothelium that was stripped, I think it's a good idea to do a histopathology, so you get a definitive diagnosis of what you are really addressing. But otherwise, case is very well managed.
What are the cases where you give oral antifungals, like you started your patients? So in which patients of ulcer, you want to give oral, and which cases?
Sir, patient presenting with infiltrate size of more than 5 into 5 mm and stromal involvement greater than two-third of the thickness of the stroma. So in that patient, we can start with systemic antifungal.
Now, what are the other indications?
So there was, if there are...
Not in your patient, in general, I'm saying, like when we get a patient of fungal ulcer, what would be the cases where you will give oral antifungal? Because we all give topical, but some patients we give oral also. So we must know when to give oral and when it is not required or when it is required. So that is what I'm trying to figure out.
When, sir, there are signs of scleritis are present, limbitis are present, deep keratitis, in such cases, we can start the patients on systemic antifungals.
Any other systemic conditions predisposing factor?
So systemic voriconazole.
No. I'm asking about indications of oral antifungals. Any systemic factor you would consider, apart from what you described about large ulcer, deeper involvement, scleral involvement, limbal involvement,
immunity related.
Immunity related, any problem?
Immunocompromised.
Which patients do you see immunocompromised? Commonest cause?
HIV patients.
How many times you have got positive HIV in fungal keratitis? Or do you ever test for HIV? Would you have tested in this patient?
Yes, sir, we have tested, sir. All routine investigations.
HIV is not routine in a corneal ulcer.
Yes, sir.
Yeah. Diabetes?
Yes, sir, Dad.
So is it not uncontrolled diabetes? Is it not an immunocompromised state?
It is, sir.
Yeah, so that is very important. Patients who are on chemotherapy for any problems, patients who have arthritis or on immunosuppression, high dose steroids, or patients undergoing treatment for cancer, neurotrophy for any, because of any reason. All these patients, these are high risk for this.
Kamakshi, thanks a
other
lot
questions?
for a nice case presentation, very interactive questions and answers we had. And now we will go to our faculty talks. Request Dr. Sushmita Shah. She's going to speak to us on management of keratoconus. So we all see these patients day in and day out, and how do we actually go about managing these patients and decision making. So I am sure she'll help us with this. And after our talk, if there are any questions, we can always ask. Yes, ma'am.
One second, sir. Is my screen visible?
Yeah.
Okay, just 1 second. There's a small issue here. I'm not able to.
Yeah, it's slider moving, doctor.
Yeah, I know, but I am not able to minimize the Zoom screen. I don't know how to do that.
Just go with the presentation. You should be able to. You are good to go.
Okay, 1 second.
I'm
going to,
put it in the slide
but
share.
half my slide is covered, so I'm not
Covered as in?
My Zoom screen. I'm not able to minimize. There are 6 screens I'm able to see, so
There should be a minus sign on the right hand side top.
Okay.
You just click on it. It will minimize. Otherwise, your presentation is clearly visible. If you want to move,
I know,
to the
I'm not able to start because this whole screen is.
You go on the Zoom screen where we are seeing. Yeah. In the left top hand corner, there is a minus.
Yes, sir. I think I got it. Yes, yes, I got it. Sorry. Yes. Okay. So, good evening, everybody. I thank Dr. Bide sir, Dr. Gokhale, and Maharashtra Ophthalmic Society for this opportunity. So, I'll be speaking on management of keratoconus. And keratoconus is a very large topic, so I will just stick to the basics of management and not go much into the other issues like topography, diagnosis, etc. So keratoconus is a bilateral corneal disease characterized by progressive thinning and steepening of the central or paracentral cornea, and has variable prevalence of about 50 to 265 per 1 lakh population. It's considered to be more in the Asian population as compared to Caucasians. The exact pathophysiology is unknown, and it is a multifactorial etiology which includes environmental stimuli or insults, oxidative stress, genetic predisposition, comorbidities, and eye rubbing. And although considered as a non-inflammatory condition, there is increasing evidence pointing towards inflammation being a driving force in causing keratoconus. So this is the treatment algorithm that I commonly follow for the management of the keratoconus. So in eyes which are if high risk of progression or are progressing, the first thing that one has to do is a corneal collagen cross-linking, followed by visual rehabilitation with glasses or contact lenses. If there is no progression or there's a low moderate risk of progression, then contact lens is a very good option. However, if there is progression and patient is not tolerant to contact lens, then corneal collagen cross-linking is again a very good option. If patient is intolerant to contact lens, then along with corneal cross-linking, additional visual rehabilitative procedures like a topography guided PRK or intercorneal ring segments can be done. In eyes that are too thin to be cross-linked and are not tolerant to contact lenses is the ultimate treatment, which is the corneal keratoplasty that has to be done. I'll describe each in detail. Now, what is progression? Now, there are multiple criteria described in the literature. So if one or more of the following changes are noted in a period of less than 1 year, then it is considered a progression. In my practice, I usually consider the first two as important. The first one being the increase in the Kmax value. This is usually the pentacam Kmax value of greater than equal to 1 diopter of increase, or a decrease in 25 micron or more in the minimum corneal thickness. As we know, in keratoconus, we already have thin cornea. So if the previous pachymetry reduces by 25 micron in less than a year's time, that is possibly progression. Other criteria could be increase in the astigmatism by more than equal to 1 diopter, or a significant change in the orientation of the refractive axis, that is the axis of the cylinder. Now, coming to contact lens for keratoconus, these have been a mainstay of treatment. They were there 20 years before, and they're going to be there for another many years. And they are extremely good non-invasive way of visual rehabilitation. This excellent non-invasive method, and it is effective both in progressive as well as non-progressive disease, and it can be very well combined with other procedures like cross-linking, intercorneal ring segments, topography guided PRK, even following transplant procedures. Now, the various contact lenses options that are available are the gas permeable contact lenses, which could be the corneal gas permeable contact lens, which we very loosely call as the RGP contact lens, or this could be the corneal scleral lenses or the scleral contact lens, which is also called as the PROS, or the prosthetic replacement of the ocular surface ecosystem. The other options include piggyback lens, not very commonly used. Herein, a soft contact lens is first put on the cornea, and on top of it is a rigid corneal gas permeable lens is applied. The other options include a soft contact lens like the Kerasoft IC contact lens, which is completely a soft hydrophilic material. And the fourth option is a hybrid contact lens, which is it has a rigid center and a soft peripheral hydrophilic skirt. So it's considered to be more comfortable as compared to a corneal RGP. Now, coming to corneal gas permeable lenses and the rose K lenses. The corneal rigid gas permeable lenses are less preferred currently because we have better options. Now, while fitting RGP lenses, there are three different techniques that have been described, which is the apical clearance, the apical touch, and the 3-point touch. So these are the three fitting criteria that one has to see when one is fitting a RGP lens. Of these, the 3-point touch is considered the most preferable. Herein, the lens supports or is actually bearing on the cornea with 3 points along each meridian, including a light apical touch and a heavy paracentral corneal touch. This is considered the most preferred fit. But the Rose K2 lenses are currently the more preferred corneal RGP contact lenses for keratoconus, and as is noted in the photograph, that is so because of the back vertex of the back surface of the contact lens, especially modified to fit the cone of the keratoconus. So they are definitely better than the normal RGP corneal contact lenses. Next is the corneoscleral and the scleral contact lenses. These are the, as I mentioned, more preferred over the corneal GP contact lens because of they are more comfortable because there is no contact between the lens edge and the eyelid so they don't keep interfering. So more comfortable for the wearer, and they are much more stable because they are larger, so they don't move that much. So the vision quality is also good. The corneoscleral are the mini-scleral or the semi-scleral lenses. They range between 15.1 to 18 millimeter. Now, there could be variations depending on the manufacturer. The scleral lenses are the ones which are more than 18.1 millimeter and can go even up to 24 millimeter. Here again, the size could be slightly variable depending on the manufacturer. So one thing I need to mention here, I think I missed on the slide, is the PROS lens, which is the first scleral lens, which was designed by the Boston Foundation for Sight, and it is made of the Boston exo material, which is a good in terms of oxygen permeability. Subsequently, the other manufacturers have come out with. There are multiple other manufacturers who also produce scleral contact lenses now. So the corneoscleral lenses, the movement with blink is less, but it is about 0.5 millimeter, and therefore it is more than the scleral contact lens, thus leading to better oxygen supply. However, while fitting a corneoscleral lenses, one has to be careful that it does not compress on the limbus, in which case it can lead to neovascularization. The scleral contact lenses are best for very advanced keratoconus, as the back surface can be customized to a prolate profile, and in a comparative study concludes that better visual performance with corneoscleral scleral contact lens over the soft contact lens has been noted. Excuse me. Sorry. And the corneal rose K2 contact lens and the corneal I'm just sorry, excuse me. Sorry. So this large study comparing the various contact lenses has noted that better visual performance can be noted with corneoscleral and scleral contact lens as compared to the soft contact lens. And the corneal rose K2 lens and the corneoscleral scleral contact lens are better than the corneal GP, that's the normal RGP in advanced keratoconus. Coming to collagen cross-linking, possibly the most commonly performed procedure as far as keratoconus is concerned, and it is now FDA approved to stop progression in eyes with progressive keratoconus. How does it work? It involves riboflavin or vitamin B2, which is a photosensitizer, and exposed to UVA at 370 nanometers wavelength, causes free radical production in the corneal stroma, which causes formation of covalent bond between collagen molecules, fibers, and microfibrils. Now, following cross-linking, there has been electron microscopic study which just noted that this cross-linking leads to increase in the collagen fiber diameter. There is increased resistance to digestion by pepsin, which is a collagenase, so it is bound to dissolve the collagen. But following cross-linking, the resistance of that collagen fiber increases, and this increases the biomechanical strength of cornea and halts progression. And currently, we have studies in the literature which has noted that the efficacy is there even after 10 years following treatment. The first protocol for cross-linking which is approved and which is most commonly done is the Dresden protocol, which involves a 9 millimeter epithelial debridement under topical anesthesia, followed by application of riboflavin 0.1% isoosmolar solution. That is, it's a 10 milligram of riboflavin 5-phosphate dissolved in 10 ml of 20% dextran solution, and this solution is applied every 2 minutes for 30 minutes, and then it is followed by exposure to UVA at a wavelength of 370 nanometers while applying riboflavin drops every 2 minutes at an irradiance of 3 milliwatt per square centimeter at 1 centimeter distance from the cornea for 30 minutes, and the total energy delivered is 5.4 millijoule per square centimeter. Important to remember that in thinnest pachymetry should be 400 microns or more to use the isoosmolar riboflavin. If the pachymetry is less than 400 or between 350 to 400 micron, one could use a hypoosmolar riboflavin for the cross-linking. For anything less than 350 micron, cross-linking is possibly not advisable. There are some nomograms which have come which enable you to do the cross-linking in even thinner corneas, but we need more, more solid studies to establish their efficacy. Now, there have been certain variations which have been proposed to the Dresden protocol. The most commonly one is the accelerated protocol or the high fluence protocol. In this, the cross-linking effect is usually lesser than the Dresden protocol, but it has still been about 7-year study, which says that it is still effective. Here, what is done differently is that after initial soaking with riboflavin, the irradiance UV light is done at an fluence of 9 milliwatt per square centimeter, same at 1 centimeter distance from the cornea for a duration of 10 minutes. However, the total energy administered is 5.4 millijoule per square centimeter, exactly same as what is applied for the Dresden protocol. The other variation which is there is the riboflavin with the HPMC or hydroxypropyl methyl cellulose. Now, the initial riboflavin that was approved contained dextran. Dextran being hyperosmolar, it pulls fluid out of the cornea and makes the cornea thinner. So HPMC is a better formulation. It helps reduce the soak time to about 20 minutes and also has effective cross-linking effect as compared to with the accelerated protocol, and the results are comparable to the Dresden protocol. Now, few caveats and complications is about the transepithelial CXL or the epithelium on CXL. That is, the epithelium is not removed and CXL is performed. Well, it's very important to know that this is absolutely ineffective and should not be tried, because riboflavin, being a high molecular weight, does not penetrate the corneal epithelium. That is one reason. Second reason being that 80% of the UVA is absorbed by the corneal epithelium. The epithelium is there. So trying to do transepithelial CXL using the same solution and same energy fluence is never going to work. So transepithelial CXL under the current conditions should not be tried. CXL complications are has been rated to somewhere about 3 complications in per 25 eyes, and these include commonest is the corneal haze. Fortunately, this is a self-limiting problem and usually goes away in 3 to 6 months. The other more severe complications include corneal edema, infiltration, corneal scarring, microbial keratitis, and progressive KC due to failure of the CXL. Again, fortunately, the incidence is pretty less. It is between 2 to 8% cases of cross-linking that do not work. So it's a fairly effective technique. Now, there are certain, as I mentioned earlier, there are certain procedures that can be done additionally along with the CXL for visual rehabilitation. One of them is the simultaneous topography guided PRK with cross-linking, which is the also called as the Athens protocol. So here we do a sequential excimer laser debridement of the epithelium around 15 micron manual debridement, and then a partial topo-guided excimer laser stromal ablation. So just about around 30 microns. The total ablation should not go more than 80 micron, followed by CXL at 9 milliwatts per square centimeter for 10 minutes. And it's important to remember not to use mitomycin C, even though you're doing a TPRK, not to use a mitomycin C in combined when you're combining PRK with the CXL. Here, the thinnest pachymetry should be more than 450 microns. It is the prospective multi-center study concluded that the results to be equivalent visual and refractive outcome 2 years after combined PGPRK plus CXL versus CXL alone. However, this was the earlier study. Some of the recent studies have said that possibly it has a better visual gain as compared to CXL alone. Long-term results are awaited, and post-op haze is important to remember and counsel patients that post-op haze could be more than CXL alone. The other combined procedure is the Cretan protocol, wherein you do a sequential transepithelial PTK followed by CXL. Herein, the excimer laser is used at an optical zone of 6.5 to 7 millimeter. The excimer laser is used to remove the corneal epithelium, 50 micron, and followed by routine CXL. The rationale behind this treatment is that once you remove the epithelium with the help of a excimer laser, its removal causes increase in the anterostromal regularity by decreasing the keratoconic astigmatism. And this has been further modified, which is called as the Cretan Plus protocol, which is transepithelial PTK followed by PRK and CXL. And here, the ablation is done after you've removed the 50 micron of the corneal epithelium. Additional about 30 microns can be removed, and this also has been shown to improve the uncorrected, best corrected visual acuity, keratometry, as well as refractive values. Now, one thing I need to mention here is that these combined procedures have only level C to level D evidence showing that about their efficacy. They are not as effective as the Dresden protocol alone is. So we'll have to still wait till the safety and efficacy of these procedures are completely established. The other combined procedure that one can do is combining CXL with intracorneal stromal ring segments. So the ICRS or the intracorneal ring segments are PMMA segments which are implanted into the deep stroma to induce central corneal flattening and reduce the irregular astigmatism. The commonly available ones are the Intex and the Ferrer rings. In India, we mostly do the Intex. The ICRS alone, it is important to remember that ICRS alone will not reduce CXL progression. So ICRS has to be combined with CXL. ICRS in combination with CXL is effective in mild to moderate keratoconus. Pachymetry should be between 380 to 450 micron. So one basic thing has to be remembered is that the PRK, which is an excimer-based procedure, will remove stromal tissue, while ICRS is more for a volume augmentation procedure. So TGPRK, the pachymetry should be more than 450 microns, so that even if you remove tissue, it does not make the cornea too thin. Whereas if the cornea has already become thinner than 350 microns, then but it is not very thin, somewhere about 400 to 380 micron minimum lower limit, the ICRS can increase volume of the cornea and can be effective. It has been shown to improve the uncorrected visual acuity with reduction in the K values. However, the two biggest drawbacks of the ICRS is that results could be unpredictable, and also it is extremely expensive. And it needs a femto, preferable to do a femto laser-based platform rather than a manual implantation, which increases the risk of the ICRS implantation manyfold. So overall, it makes the procedure extremely expensive. Other complications include extrusion and microbial keratitis. And also one thing I want to mention here, when you're doing a combined procedure, whether you're doing a PRK or a ICRS with a CXL, it is important that we do that additional procedure first, followed by the CXL, because once you've done the CXL, you would have altered the stromal structure. And then these procedures do not work as well. It makes it very difficult. Now coming to corneal transplantation in keratoconus, as I mentioned earlier, the indication is where in eyes where the corneal thickness is such that you cannot do a corneal cross-linking and the patient is intolerant to contact lens, so you have to rehabilitate the patient visually. The common techniques that are employed include the DALK or the deep anterior lamellar keratoplasty. This is the preferred surgical technique because it has less risk of endothelial rejection, early suture removal, better wound strength, and there is less risk of secondary glaucoma. The other option is the optical penetrating keratoplasty. These are specifically indicated in eyes with associated endothelial dysfunction like Fuchs endothelial dystrophy or rarely the posterior polymorphous dystrophy. And sometimes in eyes with deep stromal scar involving the desperate membrane, many times following hydrops, etc., we may the scar may be so severe that the DALK is not useful in the sense that it will not improve the vision because of the scar. The other recent technique that has been proposed is the Bowman layer transplantation, which is a newer technique. It's a kind of a volume augmentation technique in the sense that nowadays we are putting Bowman layer along with stromal tissue of thickness around 100 micron into the patient's cornea, which is thin. So it acts as a volume augmentation procedure and it reduces corneal irregularity and refractive error. However, its definitive role in stopping of progression is not proven. So one thing that is important to remember is when Bowman layer transplantation was first proposed by Dr. Mellis, he just transplanted the Bowman layer. As we all know, a disruption or break in the Bowman membrane is a hallmark of the pathogenesis of keratoconus. So the initial idea was to just remove the Bowman layer from a donor tissue. The Bowman layer is somewhere about 10 to 12 microns, so it's extremely painstaking procedure to strip the Bowman layer off the donor tissue and just create a pocket somewhere about at the 50% thickness of the recipient and just implant the Bowman layer. Now, since it has become very tedious and time consuming, the procedure has been subsequently modified, wherein surgeons are removing about 100 micron of the corneal tissue from the donor eye, including the Bowman, and then creating another femtosecond pocket in the recipient and implanting that lenticule. So that is the current status of the surgery right now. However, it's not definitive role has not been a thing in stopping progression, though it regularizes the cornea and improves the visual acuity. The last thing is the femtosecond assisted laser keratoplasty. Well, this is if you have it, you can use it for both DALK as well as PK or for any other lamellar corneal procedures. as you want. Coming to Dalk in keratoconus, as I mentioned, keratoplasty is indicated in eyes not amenable to CXL or are intolerant to contact lens or sometimes even post eye drops. The first technique which was described was the Mellis technique in 1999, wherein air is injected into the anterior chamber and stromal dissection is done by looking at the optical interface. However, this technique has been hugely replaced by the big bubble technique, which was proposed by Anwar in 2002, wherein we inject air into the stroma to create a large bubble between the stroma and the descent membrane, as is shown in the photograph below. And then the superficial stroma is excised after replacing the air with viscoelastic, and then the donor tissue from which the endothelium descent complex is removed and the donor tissue is sutured. I'll not show the video in the interest of time. So this was a case, a child with a preoperative advanced keratoconus. We could not do a CXL because the cornea was too thin. So we went ahead and did a Dalk, and he did well. Now coming to the results of penetrating keratoplasty versus Dalk in keratoconus, well, visual outcome in Dalk is dependent on the level of stromal dissection. If one has bared the desmet completely at the time of surgery,
Susmita,
then
you can just go a little faster then. So that
okay. Just two slides, 3 slides. If the complete bearing of the desmet is achieved, then a visual outcome is usually good. So the study of 11 published studies comparing PK versus Dalk has noted that the visual and refractive outcomes are comparable if the residual bed thickness in Dalk is between 25 to 65 microns. However, there are 2 studies, one from UK, one from Australia, which say that possibly graft survival and visual outcome is better in PK. However, considering the increased risk of endothelial rejection in penetrating keratoplasty, Dalk is still justified even if the visual outcome is not as great as penetrating keratoplasty. So corneal hydrops, this is a dreaded complication of keratoconus, and it occurs because of the tear in the desmet membrane leading to stromal hydration and edema. The anterior segment OCT is a very useful tool in delineating the morphology of the tear. We first published the first report on the use of perfluoropropane gas C3F8 14% for faster resolution of acute hydrops, and subsequently our next paper has also established the efficacy of the treatment. And recently in eyes that have a interstromal cleft, additional use of full thickness suture has also been described. Now coming to the last slide, since research is very close to my heart, so this is the future of keratoconus. First is the corneal stromal regeneration in keratoconus. So this involves implantation of autologous adipose-derived adult stem cells, ADASC, which is basically a mesenchymal stem cell. Now, when they put them in the corneal stroma, they start producing keratocytes, and those keratocytes in turn start producing collagen and all the glycosaminoglycans, and that is how this technique works. And this publication of 36 months data in humans has shown very promising results. Alternate are the implantation of decellularized or cellularized collagen into the stroma as a volume augmentation. The other possible therapy which might be coming is the biomarker-based therapeutic intervention. As I mentioned, it is KC is a multifactorial disease with alteration in various biochemical and mediators that contribute to pathogenesis of the disease. So therapeutic strategies to address these alterations could also be the future. Thank you so much.
Thank you, Dr. Sushmita. It was a really comprehensive talk. I think you have covered nearly all possible aspects of keratoconus. And I'll request now that we go to the talk by Dr. Ajay Kulkarni on how we manage fungal keratitis. So I'll request Ajay to share his screen. And Dr. Ajay, are there?
Yeah. Just a moment.
They can share his practical tips on fungal.
Yeah, it's already 9.
We have a quick quiz of 5 minutes and results are to be declared, which will take 5-10 minutes. So you can just.
There's some problem, not able to share screen.
What I suggest is even if you talk. And
that will be fine. I think
that will be fine. I think.
Yeah. Instead of going through the this thing. So since the target is our postgraduate students.
But you can give quick practical tips.
Dr. Ajay, can you try again? I think somebody else was sharing. I stopped it. Just try again, please. Just click on the green share screen button.
Yeah.
So Sushmita, kudos to you. You gave a really comprehensive talk on keratoconus. It's a very vast topic to cover in less time.
So, is it visible now?
Yes, it is visible. Yeah.
Yeah, so I'll directly go to basically management, I mean the medical treatment as well as surgical treatment. The first and foremost is to establish the diagnosis. We should be very clear that we are dealing with fungus. So on the first contact with the patient, one has to do a corneal scraping, and the case which was presented highlighted that it is only KOH is not sufficient. You have to also do gram staining because you might be dealing with more than one bug in certain individuals. So routinely do a gram staining and a KOH mount. Once you establish that you are dealing with fungus, then you start targeted therapy. If you are dealing only with fungus, the antibiotic, topical antibiotic is not really required. You can continue only with topical antifungus. And debridement of epithelium is important because there are two issues here. One is many times these patients will have a presentation of a plaque-like infiltrate on the cornea. So you debulk that up to the level of the corneal surface, and the 1 to 1.5 millimeter normal-looking epithelium, which is beyond the visible edges of the infiltrate, which is because that is the advancing age. And we want our antifungus to reach in that area where the ulcer is growing. So this is very important on first visit. So the agents which we have available are natamycin and voriconazole and amphotericin B. We know that voriconazole and amphotericin B we have to prepare, and it has to be prepared in sterile conditions because contamination of these medicines is also a big issue. Many times we don't really look into that. And natamycin is commercially available. We all know. Fortunately, 80% of all fungi would respond to natamycin. Only in few cases we would have to consider supplementation either with voriconazole or with amphotericin B. When it comes to systemic antifungals, my choice has always been itraconazole because it is very well tolerated as compared to ketoconazole, and the derangement of liver function is not very commonly and earlier seen with itraconazole. So given the choice, itraconazole 100 milligram would be my choice when it comes to systemic medications. So many times it might happen that we are dealing with this thing, fungus, and clinical suspicion is high and the smear is negative for fungus. So as was pointed out by Sushmita, if you are not getting the organism, you should rescrape. Corneal biopsy again is a procedure where you have to take the patient in the theater. So it involves the other logistics as well. But by all means, you should avoid empirical therapy. So how does one make a judgment of improvement? Or is there any role of corticosteroid in the management of fungus? When to intervene surgically, or when do you say that medical treatment is not working? And what to do when the ulcer does not respond? So these are the questions we commonly face in our clinical practice. So the judgment of improvement is that all of us are aware that the signs and symptoms would reduce, and you will see or notice scarring at the advancing edges of the ulcer. A word about endothelial plaque and hypopyon, because we were discussing about hypopyon, its height, and when to intervene or not. One has to remember that as the ulcer starts responding to the medical treatment, the endothelial plaque starts liquefying, and it will settle because of gravity in the form of hypopyon. So if you see there's a slight increase in the level of hypopyon, do not label it as non-responding ulcer. So you primarily go by what is happening at the level of the corneal infiltrate. So if you see that there's scarring all around and the infiltrate looks more of white, the yellow color fades, and the symptoms and other signs are down, don't really bother about waxing and waning hypopyon. have patience. Recovery, all of us know that it takes around 6 to 8 weeks time. And since the other areas of our ophthalmic practice, we are obsessed by speed. Here it is not the time that is more important. Is you have to give 6 to 8 weeks time for complete resolution. Ignore conjunctival signs. Why I have written this is because many times 1 hourly drops can cause a lot of conjunctival reaction. So basically you go by what is happening at the level of the corneal infiltrate. So sometimes in spite of best efforts, the infection worsens. So we have to rule out other issues. We just talked about that. Rule out diabetes, check with the compliance. This is a major problem. We never check with that. Possibility of mixed infection, you should be considering drug toxicity and reinfection through contamination of drops, especially when we are giving them after reconstitution. So do whatever you can, it doesn't come under control. Then what? So then the role of surgery comes in. Epithelial debridement right from day one, but don't debride every day because it's an inflamed cornea. And when you debride every day, you are actually increasing injury to the cornea, which itself can cause increase in the inflammatory response in the cornea. So if you notice that the epithelial defect is larger than the infiltrate, you don't have to really debride every day. Certain cases, the fungus can actually increase very fast and lead to actual or impending perforation. And classically, it is thought that if the perforation is small, less than 2 millimeters, you glue. But I have glued even larger perforations up to 4.5 to 5 millimeter as well. As an all-out measure, if you don't have anything at hand, you still can glue them. And therapeutic keratoplasty, it is important to note that the timing of therapeutic keratoplasty in fungal keratitis is of prime importance, because if you wait too long, then you might lose the battle. And one should not be very over aggressive in subjecting these patients for therapeutic keratoplasty. Earlier, if you have 2 to 3 millimeter clear corneal margin, you should give a fair amount of time for medical treatment. This is just to show you a central ulcer which perforated and glued. The glue works very nicely. There has always been an issue that if you glue a fungal ulcer, then the penetration of the antifungal would be affected. But clinically, we do not see that. There is no worsening of fungal keratitis after gluing. So glue also, we very well know that glue has antibacterial properties, but it also has certain antifungal properties as well. And even large ulcers, sometimes can result in a very big corneal scar, sometimes adrenaline but don't be in a hurry to post these patients for optical PK. Herein, I would like to focus the attention on the pupil. So pupil is seen in the clear part of the ear. The scar is peripheral. Many times these patients do enjoy a good vision of 624 to 612. So in these cases, just you can improve the cosmesis by other methods, but don't subject these patients for therapeutic or the optical keratoplasty. So with this, I would like to conclude about the salient features about how to pick up fungus and what are the management issues and how long we have to continue treatment. 2 important points. If you have to give systemic antifungals for more than 3 to 4 weeks, get a baseline LFT done and repeat LFT after 3 to 4 weeks, because if the liver function is deranged, you should not continue with systemic antifungals. That is very important. And after complete resolution of fungal ulcer, you have to continue topical antifungals for at least 15 to 20 days. Thank you, Dr. Santosh and Dr. Nikhil, for this opportunity. And I thank MOS also.
Thank you, Ajay. It was a nice, crisp, and the correct messages that I think practitioners will look at and postgraduate students would look at. So I think we can go to quiz. Dr. Santosh, how do you do it? Yeah. Just go ahead, I think.
Sunil, are you there?
Yes, sir.
Let's start the quiz. I hope everybody knows the first question. There are 15 seconds. So first question is shield ulcer is seen in. These are the 4 conditions and the time starts now. Sunil?
The poll is on the screens. Please do
Yes.
not mention anything in chat. Put everything on the screen. Closing in 5 seconds. Closing the poll. That's a correct answer. Next question.
Yeah, next question. This is the second question.
Should I launch the poll, sir?
Yes, please. Go ahead.
The option is on the screen. Please select the correct answer. Do not write anything in chat. Five more seconds. Closing the poll. Correct answer is on the screen.
Question 3. KF ring is seen due to
Launching the poll on the screen.
Yeah.
Five more seconds. Stopping the poll. Correct answer.
both questions. Let's just ring.
Should I launch the poll, sir?
Yeah, just wait for a second so that everybody reads it and then you launch.
Sure, sir.
Yeah, you can launch now.
Sure. The quiz is on the screen. Five more seconds. Stopping the poll. The correct answer is on the screen.
Now the last question.
Should I launch, sir?
Yeah, but you have not given options, no, for people. Have you shown the options?
Okay, sir.
The next slide, yeah. And now you can launch the poll.
Sure, sir. The option is on the screen.
Yes.
Five more seconds, please. Stopping the screen. That's the end of it.
Yeah. Yeah. So now can you share the last month's result also, compiled result?
The compiled one, for both.
Yeah, compiled one, because last time we had shown, or you want to show the only part 2, because there were only 2 people who answered correctly.
Yes, sir. I'm just downloading, sir.
Just a minute,
I'm sharing, sir.
yeah, no, my computer is going to die now.
So I'm just increasing the size in case the visibility is low. Sorry. These are the two persons.
These are the two people who answered all 5 questions correctly. Dr. Apurva Jadhav and Sachin. So results of this quiz will be declared in the next PG teaching activity, which will be there on 18th of January. Topic will be again cornea. And I request everybody to participate in that also. And I request, I think, Dr. Rajesh Joshi, I would like to thank Dr. Rajesh Joshi, Dr. Bhatti sir, Dr. Sushmita Shah, Dr. Ajay Kulkarni, Dr. Sabnis sir, Dr. Patil madam for contributing, and of course, Dr. Nikhil Gokhale for actively participating in this PG teaching activity. A quick words from all of them, maybe one minute each, regarding this activity and how we can improve it. Dr. Ajay, you want to say something?
Yeah, I mean, the presentation by the postgraduates or the residents should be on the lines where what is required in their examination, because Dr. Joshi and Dr. Bhatti, they are in the best position to comment on that. And we should place more emphasis on clinical science and actual description of the clinical picture. Theoretical and all, everything is available on Google. I mean, that's not an issue. So my emphasis would be largely on picking up clinical science and how to examine and document the findings.
Dr. Rajesh, you want to say something?
I was just wondering, of course, they had pictures this time, but they can also try to draw the corneal diagram, because in the exam, I think possibly they'll have to draw it, you won't have picture possibly. So how to draw and color code them, and that was important for all postgraduates, I think.
And I think another aspect is that most of them concentrate on filling in the relevant sort of, you might say, fill in the blanks in the presentation. But after they fill in the blanks in the presentation, they should also spend some time thinking as to how they came to the diagnosis of the etiology, some factors that may concern the diagnosis and the treatment. I mean, think a little around the topic as well, not just purely the fill in the blanks of the presentation.
And one more thing I would like to say, for exam point of view, they have to follow a certain protocol. Like they have to follow, they have to first tell us about the chief complaints, then the history of present illness, then the negative history. So there's a protocol for it. So, and then the torchlight examination, then the slit lamp examination. So this is, I know this is a very concise form, and they have limited time. But then they should not miss that protocol, because they have marks for that. And like we as examiners, we deduct their marks if they don't follow that protocol. And for example, in the first case, he was saying there's no history of photophobia. But then that is, the history should only be in patient's language. You cannot use the scientific terms when you present your history. So that also I wanted to say, because when in your exams, here it is okay. But when you're presenting a case in your exams, you should not, you cannot use these scientific terms, because the history has to be in patient's own language.
And another one small point is, I always like to emphasize on the residents that when they present, though they have to try and be complete, but the emphasis should be on 3 points. One is those facts which help the diagnosis, those facts which rule out the differential diagnosis, and finally those facts which may affect the treatment. And if these 3 criteria are not met, then though the findings may be in the fill in the blank pro forma, but they don't need to be emphasized that much. They can be just swept over in passing, and you must stop over and emphasize and concentrate on these 3 points: facts affecting diagnosis, facts affecting differential, and facts affecting treatment.
I think I'll also agree with what Bhatti sir said and Archana ma'am said, that the format and the protocol has to be followed, and I think it's very important to have a differential diagnosis, not just the diagnosis. Say, for example, the first case about the bullous keratopathy, so the possible differential diagnosis which could have caused that pseudophakic bullous keratopathy should be listed, and only then the student starts thinking, okay, what could be the possible? It could be an instrument traumatic surgery or a Fuchs dystrophy, asymmetrical, or even a far-fetched possibility of an endotheliitis post-cataracts. These could be the 3 possible differentials, and then you start thinking about how to rule out each and everything, and then you come to the diagnosis. So unless you have a differential diagnosis, coming to the diagnosis is always it becomes difficult. So that approach, like what Archana madam also said, that the protocol has to be followed in the right way. That's important.
And the student should not, start the first slide that I'm going to present a case on fungal keratitis, or I'm going to present a case on pseudophakic bullous keratopathy. They should not, reveal the diagnosis in the first slide itself. They have to go in a particular way. So they just cannot jump onto the diagnosis in the first slide itself.
Very good take-home messages for students, I think. Yeah, thank you. So once again, thank you to everyone. Yeah, somebody was saying something.
Thank you, sir. Good night.
Thank you, and that was a really lovely
Thank you to everyone, and Happy New Year. And
Happy
see
New
you
Year.
again on 18th of January. And hope we continue with this activity. Thank you. Thank you,
Thank
Nikhil, for all your help.
Thank you.
And
Thank you. Thank you, everybody. Good night.
Thank you.
Right.
Bye. Good. Yeah. Excellent talk, Sushmita madam.
Yeah, I'd also like to thank everybody, and especially
Thank you.
Thank you,
Dr. K.
Bhatti sir. Yeah, thank you.